OCT guided corneal and anterior segment surgeries, and we've become so used to it that we are, now it becomes difficult to operate without having one, especially the corneal and the ocular surface surgeries. Now, the intraoperative OCT is available with various options, but I'll be talking to you about the microscope integrated one, OCT. I think it's again, I can't see the, sorry, I can't see my own presentation here. There's, so advantage, I think, has been very nicely highlighted by Zai that real-time images, dynamic visualization, both planar and cross-sectional can be seen. The only flip side is that it is expensive and it may not be available at all the centers. And this is something that we did describe earlier, that if we have a anterior segment OCT and if there are DMD such as like this with scrolled edges, you inject air, you defer a corneal transplantation procedure. But this is in the era of when intraoperative OCT was not available, and this is the time when intraoperative OCT is available. And so when you inject the air bubble for a Descemet's membrane to attach itself, and I also showed very well, but if you didn't have this at this point in time, you would think that you are done. But look at the cornea, it is hazy. So when you know it is pretty much attached, the cornea will also become clearer. So it's becoming clearer. You have to keep that positive pressure for some time, and as you take out your needle, there may be a shallow Descemet's membrane detachment again like this, and then you have to go in there and then ensure that the air bubble doesn't come out. So put some pressure there, or put a blob of viscoelastic there to show the same. Now, again, this is to show the Descemet's membrane detachment. This was, of course, post-keratoplasty. And the post-operative course is so stormy that you can't make out where the Descemet's membrane is if you didn't have this right half view. But now air bubble is instilled, and you know that there's still some gap which is present there. And again, if I didn't have this, I would think that, it is done, but it is actually not done. And then when you do intrastromal drainage from the top, the Descemet's membrane does oppose a little bit, and if you put the air bubble, it is now completely opposed. So it allows you to see microscopically what you cannot visualize with the eye, and this is the case in the post-op period, pre-op and post-op. Now, we did publish the management algorithm of DMD based on whether it is plain or scrolled edges, and whether air or SF6 or C3F8 should be injected. So if it is a planar one and in the superior halves, air will do, but for the rest, all the ones in inferior, whether it is planar or scrolled, or superior if it is scrolled, SF6 or C3F8 should be done. Now, when you are doing a big bubble, type 1 or type 2, if you are above Dua's layer, then it's a rough surface like this and it is type 1 big bubble. And if you are below Dua's layer, then it is smooth surface like this and it is a type 2 bubble. And again, I'm again emphasizing what Zai has already shown you, that when you put the air, uh, uh, inject the air at 90% depth, the Descemet's membrane falls back, and you can actually see this is the inverted image. And like I said, you do need a technician there to keep adjusting your IOCT, because that little bit of learning curve is there. This was in the older model, now it is not there in the newer models. So when you give a nick in the overlying stromal layers, you can actually see the Descemet's membrane going towards the stromal layers, and then you know that you are in the correct plane, and you also know from wherein to inject the viscoelastic. So this is the viscoelastic which is being injected. So the Descemet's membrane falls back, and then subsequently on this cushion of viscoelastic, one can excise the stromal layers, and the Descemet's membrane stares at you, and then a full thickness donor can be placed. When you're doing a type 2 bubble also, at that time also it helps. So the level of the needle you come to know, because it will be 90% depth. And look at this is a type 2 bubble because it is coming from the periphery. Stop short here because I didn't want to go right till the end, because if I did, then when you do paracentesis, this might perforate. So just stop short here. That's it. And then do the paracentesis because it's quite stuck in this area. And then as you do it, you can see that the air will egress out very quickly because this is a type 2 bubble. So the moment you give a nick, It will be a very quick movement, unlike the type 1 bubble, which is a very slow movement. Just this is unedited, the egress of the bubbles, the way it came out. And then again, you can just put viscoelastic there and do your dissection as was shown previously. Again, in healed eye drops, it is very useful because in case of healed eye drops, you see the scar that is there, and then you can focus here. Wherever this pink and blue thing will be, that will be your point of focus or intersection. And when you come to that area, leave little bit of stroma there. Just go a little more anteriorly as guided by the intraoperative OCT. So this is removed, but that little bit of scar is there, and this is in the paracentral area, so it doesn't matter. It will not impact the visual axis. So this is just to show the same, that it has moved in the periphery here, and the 52 microns of stroma remains and the visual acuity is good. Then Dr. Vajpayee did describe this technique of intrastromal fluid drainage in cases of acute eye drops. At that time, we used to do it with ASOCT, but now we have this intra-op OCT microscope, so you can actually give puncture marks in the area of the fluid clefts which are there, and then again put the air bubble so that you tamponade the whole thing, and your endpoint can also be titrated when there are no dark areas or clefts remaining at the end, and then you know that you have done the thing completely. Again, this is just to show how when you do OCT guided resolution of acute eye drops, it does help, and it does clear up like this over a period of time. Then in case of chemical injury like this, limbal stem cell deficiency, referred for corneal transplantation. But in all these cases, what happens is if you remove the pannus, you would know what is the level of the pannus and what is the level of the cornea. And in chemical injuries, the cornea can be really thinned out. So it is very useful. And this is a slit which is being done. And you know that the cornea underneath is clear, it is intact, it has got adequate thickness. So one can, do a slit procedure and get away with it. So 600 microns, and this is the post-op picture, visual acuity of 6 by 6. Now, like I said, in chemical injuries, it is very useful. Again, this is a case of chemical injury where there was symblepharon present. So 360 degrees peritomy is done. And then again, you have to look at the, do a dissection like this so that you remove the entire pannus, and then do a slit there, and then also this requires a symblepharon ring because there's symblepharon present and you don't want that to occur again. Then in this case again, this is a deep anterior lamellar keratoplasty which is being done after doing a surface procedure. So sometimes after doing a surface procedure, the haze will still be there. So you do dissection and you look here at what level you are. Now it's hazy and you can still go further by looking at the by looking at the intersection of the keratectomy site. So this is removed, and finally you remove the layer till the time that you get a clear cornea like this here. And now you know that you are still about 100-150 microns away, and then the graft can be sutured. If it is very thinned out, then you can even do a corneal transplantation procedure with it. In case of descemetocele like this also, it is very useful. So this is a case of descemetocele in which this tissue is put and this is glued. The patient, this is being done under topical anesthesia because patient was of meningitis, and the general anesthesia people didn't take, and we couldn't give a peribulbar because of such a large descemetocele. Now you can just titrate. Here there is a gap present, so you'll have to push it a little more to get that perfect apposition, and when you keep pushing it with the glue, you do get a perfect apposition, which you can see on the intraop OCT microscope. So this is the post-op picture, and this patient is awaiting a penetrating keratoplasty, but it helped us to save the eye at that point in time when the patient was having descemetocele. Then sometimes you have keloid and you don't know whether it is a keloid on the ASOCT, of course you can see, but you can remove the keloid on the IOCT also. And as you remove the keloid, you'll see that the underneath cornea is clear and it is shining, and it is of normal thickness. So just notice that here you have a total cornea which is absolutely clear. Then even in cases of shield ulcer, you can know the depth of the shield ulcer. So this can be removed, and then amniotic membrane can be, two pieces of amniotic membrane are being cut here, one a smaller piece and the other a larger piece over this, and the same dynamics of these can be seen very easily on the intraoppository microscope. Even in pterygium, which look like this, and you don't know what is happening underneath, you can look at the intraoppository microscope to see that there is a pterygium and there is cornea which is not that thinned out, and so the surgery can be undertaken. And when it is thinned out, then also you can make out and adequately modify your surgical procedure. Then Zai very nicely showed about the DSEC grafts. So when the DSEC graft is being pulled, especially in terms of hazy corneas, you can actually see. Now here, if I was to just see this left half, I really don't know where the graft is, but I can make out as I see the intraoppository microscope. It's folded on itself. And now it's kind of opening here, but not quite so as one would like to be. And then when you put the air bubble, you think it is done, but it is not done because there's some movement of the graft as hydration of the wound is done. And then again, air bubble is instilled and hydration of the wound is done. And look at the way the graft moves. So you would think, it is over, but it is not over. Now, again, when you have a very thin graft, this was a very thin graft and it got flipped. We couldn't make out because of the hazy cornea, which side is endothelial side up. So we looked at the intraop OCT microscope, and if it is like this, that means it is opposite because endothelium will look down like this. So you have to get it into this configuration, and then you know that this side is up. So again, a very useful tool in such cases, especially with hazy corneas where you can't make out which side is up and which side is down, which can occur with ultra thin DSEC, also can occur with your DMEX. Now this is a case of post PK DSEC cataract. So this is just to show that you would think that the graft doesn't move, but when you do a cataract surgery, you can actually see live what happens to the graft. So up till now, the graft has not moved at all, but now towards the end, there is a gap present. So if this occurs, then one can, put air bubble and then get it to attach at the end of the procedure. Sorry. Now, this was a case of Gufthalmos in which we did a DSEC graft. And this is again a DMEC, very useful, although you don't need to make a DMEC roll in intraoppository microscope because you can see it with a trypan blue dye. Triphinate the cornea and fashion a Descemet's membrane roll. You can see the mechanics here, and sometimes when there are adhesions here between the Descemet's membrane and the underlying stroma, you can make out, but you can still see that even with the trypan blue. So probably it is not needed for this. But when you're doing a DMEC in a patient like this, a case of Fuchs dystrophy with cataract, where cataract surgery has been done, so all the Descemet membrane remnants that are there need to be taken out and need to be removed. And this is the pure Descemet's roll which is being taken. And this needs to get into that biceps curl upward configuration so that you know that this is inverted graft now because it's biceps down. So you have to get it to a biceps up curl like this, a biceps curl up configuration. And then you know that it is the endothelial side up. And then as you put the air bubble, the graft gets stuck to the back of the cornea. So this is post-op week 1 and this is post-op month 1. You can't make out the graft was there also. Then, like I said, whenever the media gets hazy, you put a stamp there for DMEC, but this is a stamped graph which is being used, but you really can't make out what is happening to the graph except for the configuration which is here. And it's a tight scroll. So you tap to unscroll it. And now look at this, it is biceps curl upwards. So when it is biceps curl upwards, I can't see the S-shaped stamp here at all, though faintly one can make out the S. And then you know that you are in the correct configuration. And the resolution of this is really good. You can make out very easily, especially the newer microscopes with this. Then this will get too technical. Even in eye syndrome, when there are synechiae present, one can remove the synechiae. The Descemet's membrane can be, descemetorexis can be done, and then we can do the DMEC just as I had described earlier, getting the correct side roll up and then putting a air bubble there. So in eye syndrome, it just helps to identify where the synechia are. And in the post-op also period, you can ensure that iris is not touching the back of the cornea. And this is the post-op picture of the same with clear cornea. Then when you are doing repeat desec such as this, and there is a synechia present here, of course you can see it, but here also you can identify this was the cause of the failed desec in this case. And now just when you're loading also, you load it with the biceps curl up. So it helps you. So when you put it, it's a biceps curl up which goes in, and then you tap, and again you can see that there's some amount of reaction which is here. But then you tap and put the air bubble, and the graft gets stuck, and the correct S stares at you, so you know that you are in the correct direction. Now, I found it very useful for MIOCT guided rescue of lenticule, especially when you've done too much of needling and when you are in your learning curve. Then you can use IOCT for this very useful tool. So one can, see where your lenticule is, especially if you've done too much of needling and you can't make out whether it is adhered to the cap or to the bed. So one can see on the IOCT where the cap, where the lenticule is, and can dissect accordingly. So you don't have to call the patient the next day after doing ASOCT to see that. You can do it at that time only. So to conclude, intraoperative OCT is a useful tool in armamentarium of corneal and anterior segment surgeons, and it's like a third eye. It helps you to sorry, it helps you to see the unseen, and helps you to titrate all your steps in a much better manner.